Thank you very much. I'm very happy to be here with you today. After the analysis that Georgia made for the calculation of GI and GL in the Greek population, we examined whether dietary glycemic index or glycemic load were associated with metabolic syndrome. A few words about metabolic syndrome. Metabolic syndrome is a term used to describe a combination of risk factors that indicate an increased chance of developing cardiovascular disease and diabetes mellitus. These risk factors included elevated fasting blood glucose, raised blood pressure, elevated triglyceride levels, low high-density lipoprotein cholesterol levels, and obesity. Epidemiological studies have shown that dietary glycemic index and glycemic load contribute to the development of components of METs, such as elevated triglyceride levels or low HDL levels. Previous observational studies have investigated the GI and the GL of the diet in relation to the METs, but the results are mixed. Some of the inconsistencies are the gender, the dietary assessment tool used, the sample size, and the adjustments for confounding factors. The prevalence of METs differs according to the definition, geographical location, and population. The global prevalence of metabolic syndrome is estimated to range between 12.5 to 31.4%, while in Europe it falls between 13 to 36%. In 1998, the World Health Organization became the first organization to introduce the term metabolic syndrome, primarily focusing on insulin resistance and hyperglycemia. After that, several definitions were proposed by different societies, which mainly differed in their clinical evaluation of abdominal adiposity. In 2009, the International Diabetes Federation Task Force on Epidemiology and Prevention, along with the National Heart, Lung, and Blood Institute, the American Heart Association, the World Heart Federation, and the International Atherosclerosis Society, released a statement that harmonized the criteria for defining metabolic syndrome. This is the definition that is in use today. In the IDEA study, the uniform criteria were used to calculate metabolic syndrome. In the absence of fasting glucose result, we utilized glycosylated hemoglobin as a criterion to evaluate glucose metabolism. Furthermore, as you can see, for the elevated waist circumference, we use a cutoff of higher than 102 and 88 centimeters for males and females, respectively. Nutritional data were available for 3,951 of the 4,011 IDEA participants. For this analysis, we are also excluded women who were pregnant at the time of their interview, participants with low average energy intake, less than 500 kilocalories over the 224 dietary recalls, and those whose metabolic syndrome status was unclear. The final sum included 3,835 persons. The aim of the study is to assess the association between glycemic index or glycemic load as exposure and metabolic syndrome along with its individual components as outcomes. This cross-sectional study is adjusted for confounding factors including age, sex, BMI, energy intake, and lifestyle covariance. For the analysis, logistic regression was used while we using GI or GL tertile as covariance. This table and the next one show the effect of different covariants on metabolic syndrome in the presence of either glycemic index or glycemic load. The results indicate that sex was not significantly associated with metabolic syndrome in either model. However, AIDS show a clear increasing trend with the odds of having metabolic syndrome rising across age groups. This slide shows the prevalence of metabolic syndrome by sex in different age groups. The overall prevalence is 25.6%. It can be seen that the prevalence of metabolic syndrome increases with age in both males and females. Males have a higher prevalence at younger age than females. However, after the age of 55, the prevalence among females catches up with that among males, and by the age of 65 and over, females have a higher prevalence than males. When we examine the effect of age separately in males and females, we can see that while metabolic syndrome increases progressively with age in both sexes, females exhibit constantly greater odds ratio compared to males in each age group. However, when we adjusted this model without the significant covariance, the effect of age in males and females was found to be similar, both in the presence of GI and the presence of GL. Among the examining factors, both age and body mass index show a strong positive association with metabolic syndrome. Higher triglyceride levels were more prevalent among males, individuals with higher BMI, and current smokers. Similarly, low HDL cholesterol was associated with increased BMI, smoking status, and individuals belonging to the highest tertile of glycemic load. Hypertension was linked to older age, high BMI, males, and individuals being in the second tertile of glycemic index. Diabetes was also positively associated with age and BMI. Lastly, elevated waist circumference was observed more frequently among individuals with higher BMI, older age, and those in the highest tertile of glycemic index. Overall, these findings highlight the significant impact of age, body weight, and lifestyle factors, such as smoking, on the different components of metabolic syndrome. As we mentioned before, the IDRIA survey is a cross-sectional study. Meta-analysis of observational studies have shown that a higher dietary glycemic index is associated with an increased risk of metabolic syndrome, except for studies that use 24 hours dietary recall for dietary assessment. As we used the 24 dietary recall for our dietary assessment, maybe a reason why did not find an association between metabolic syndrome and GI or GL. Another issue is that we identify an association between certain components of metabolic syndrome, such as low HDL, hypertension, and elevated waist circumference, with glycemic index or glycemic load, but not with others, including diabetes and high triglycerides. This discrepancy may attribute to dietary recommendations for managing these conditions. I also want to mention that Greek diet reflected in the IDRIA data is relatively low in carbohydrates and high in fats, largely monosaturated. This macronutrient profile may explain the limited evidence observed for independent association between glycemic index or glycemic load and metabolic syndrome in the Greek population. For the future, I think that more prospective studies are needed to clarify the relationship between metabolic syndrome and GI or GL. Thank you.